All right. Welcome everyone to the We Are the Resistance webinar, Communities Advancing New Cures for TB and Fighting AMR. We are so thrilled to have you all today with us. We'll be getting started right now because we've got a really packed agenda. So before we dig into the content of the webinar, let's go through a little bit of housekeeping. I'm really pleased to share that we have simultaneous interpretation available on today's webinar, with a shout out to some of our partners, such as Yuri at YKI for helping to make that happen, for Bahasa, and Christina from PAS in Moldova for helping to make that happen in Russian. We really appreciate your collaboration. Teamwork really does make the dream work. So today we have Russian interpretation, we have Spanish interpretation, and we have French interpretation. So go ahead and navigate to those spaces if you'd prefer to listen in those languages. We also have Bahasa and Hindi. Unfortunately, Zoom does not have a label for every single language and not Bahasa or Hindi. So you'll find Bahasa today labeled as Japanese and Hindi today labeled as Korean. And this is just a reminder to all of our speakers today, please try to speak slow-ish so that our interpreters are well positioned to translate for us. I also want to flag that this webinar is being recorded, so please keep that in mind. And if you happen to be taking to social media and live tweeting or Xing or Instagramming today's discussion, please do use the hashtag 6monthsmax. And for those of you who are just getting to know Fast Track the Cure, Fast Track the Cure is a community-led initiative that was created really to raise awareness of and expand and accelerate access to new treatments for tuberculosis. As a group of 4 implementing partners, we launched initially in 2023, and we are currently focused on ensuring and securing rapid and equitable access to the new 6-month BPAL-M treatments for drug-resistant tuberculosis. And as of today, we have 36 endorsing partners also supporting this work and 2 sponsoring partners. So why are we here today? Well, some of you might be aware that coming up next week, there is a high-level meeting on antimicrobial resistance taking place at the United Nations General Assembly. And as a community, we have been working really hard to make sure that TB is prioritized within that agenda and political declaration, as well as commitments to actions from member states, because TB is the leading cause of death in antimicrobial resistance. So a third of all AMR-related deaths are actually from drug-resistant TB. So we need to be making sure that TB is a part of this discussion. And luckily, thanks to a lot of the advocacy and work of many of you here today, the final draft political declaration for the HLM on AMR actually does acknowledge that drug-resistant TB is one of the key components of the global challenge of AMR. And within that political declaration, there was also a commitment to ensure equitable and timely access to and greater supply of antimicrobials, vaccines, and diagnostics, especially in low and middle income countries. So this is a great commitment to see and is nicely aligned with the work that we're doing here with Fast Track the Cure. But we actually have more of a specific ask for member states that are participating in the high-level meeting in AMR. So there is a new treatment for drug-resistant forms of TB that exists today and that is recommended by the World Health Organization for most people with DRTB. This is called the BPAL-M regimen. BPAL standing for bedaquiline, fortomenib, linezolid, with or without moxifloxacin, specifically in the case of documented resistance to fluoroquinolones. And this regimen is more effective than older other treatments for DRTB. It has a cure rate of about 90%, whereas other regimens and treatments have less than a 60% cure rate. It's simpler. So just look at this picture on screen, comparing 1 day of treatment with BPAL, BPAL-M versus other DRTB treatments. It's shorter, lasting only 6 months, whereas other regimens would take 9 to 18 plus months to cure. It's more cost saving to the health system, to the individual with DRTB, and also in terms of cost of the treatment itself. And there are less side effects. So what do we want to see? We as a community, we want to see world leaders at the upcoming AMR commit to making sure that there's universal access to this new, shorter, and effective 6-month DRTB treatment by the end of 2024. And this ask might be familiar to you. It aligns with the 1x4x6x24 campaign. And it is also the ask that the TB community rallied around in the lead up to the high-level meeting on tuberculosis last year. So as a Fast Track the Cure community, we launched a petition making this ask loud. And we would love to have your support. If you haven't signed this petition yet, you can take out your phone, scan this QR code, and do so right here, right now, because we are going to be passing over the results of this petition at the high-level meeting next week in New York. So to learn more about this new regimen, as well as to understand how the community around the world is the resistance, you're going to be hearing from a diversity of stellar keynote speakers today and a panel of our Fast Track the Cure implementing partners who are doing critical work to speed and ensure smooth adoption of BPAL, BPAL-M in India, Indonesia, Vietnam, and the Philippines. So I'm going to actually stop sharing my screen now so that you can hear from Dr. Erlina, who has been referred to as one of the top crusaders against TB in Indonesia by the Global Fund. She has treated tens and thousands of people with TB over her 30-year plus career, and she is actually one of the first prescribers of the BPAL-M regimen in the world, with Indonesia taking on early operational research to see how BPAL-M performs in real world settings. So she has lots of knowledge to share with you today. I'm going to stop sharing my screen so you can hear directly from her. Erlina.
Thank you, Robin. Hello, everyone. I'm Erlina from Indonesia. I'm a pulmonologist. So I start treating DRTB patient in 29 back then. And we had a very long regimen during that time, like 18 to 24 months, very long. And also with a lot of pills and also injectable drug. I remember having that regimen very long until 2 years, yeah, and also with so many drugs and with injectable drug, my patient were suffering. They got a lot of complaint and side effect like dizziness, imbalance, nausea, vomiting, and many others. Even some of them having a hearing loss. That was a very bad experience. And I was not that smart during that time. I felt so stupid during that time that I have to say to my patient, please take the drug, even though you have this hearing loss, but you have to choose. You get better, but having this hearing loss, or you don't get hearing loss, but you're not being cured. I think that was so very difficult for me to say, but I did say it. Now I feel so regret saying that to my patient after knowing this new regimen. So with that longer regimen, I remember there are so many of my patients lost to follow up or stop the treatment. Around 20% due to the side effect. They said they cannot afford to have this side effect. They were so suffer, and I can't tell you how difficult with this patient, yeah. And many of them said, okay, doctor, I know you want to help me, but I can't do this anymore. Please let me go. I don't want to proceed with this procedure. I'm so sorry and never come back. Yeah, there's a lot, maybe like 20% of them, but actually it's increasing number of not only having lost to follow up, they don't continue the treatment, but also they are saying from patient to patient, like not rumor, but actually that's the fact that, oh, don't you ever start? I'm suffering. And a lot of my patients who then already diagnosed as DRTB, but never initiate the treatment because they're afraid. They heard the experience of their peers group. That was really a very sad situation. You know, uh, during that time, Indonesian success rate never achieved more than 50%. And we had a lot of the patient. So even though later on we have this 9-month regimen, but still with injectable. And later we have 9-month regimen or oral, but still 7 different kind of drug. I remember during this 2-month regimen, many of my patients complain of taking the pills over 17 pills. I remember one of or two of my patients said taking 30 tablets and got injectable every day for 6 months. That was really terrible. Now, when I remember that, I felt so sad and so sorry for my patient. And I come to have knowledge of this new regimen, 6-month regimen of BPAL, bedaquiline, pretomanic, and linezolid, plus or without moxifloxacin. When I attending the union meeting in Hyderabad, India, I think in 2018 or 2019. That was the first time I see the presentation of my colleague from South Africa, and I said to myself and also to the group of Indonesian physicians, we have to change our regimen. We have to use this 6-month regimen. But there is so long and so many challenges to have that regimen in my country. We have to make like to develop a protocol for this operational research. We have applied. We have to get approval from the NTP. We have to have some party to support these activities. And finally, we start this regimen, the 6-month regimen, in 2022. That a year after the rapid communication from WHO that we are recommend to use this 6-month regimen. I was so happy, and I was the one who prescribed my pre-XDR patient using this BPAL regimen. And I can see the light of my patient eyes saying, "Oh, doctor, thank you so very much." I heard uh, from other patient that the duration usually for uh, 2 years. I don't think I can take it for 2 years, but now you give me the new hope, saying only for 6 months. And they're also happy knowing that the tablet, the pill was less in numbers. And of course, in the beginning, we have also the adverse event, especially with linezolid, because I remember we used 1200 milligram milligram of linezolid, and many of my patients got this anemia. But I think all the side effect or adverse event were tolerable, and we were so lucky. Then WHO changed the doses half to 600 milligram, and that's really a changer. There was so small number of my patient feel the side effect and think even better. And I have to tell you this. Even with the clinical trial, the success rate is just like 90%. In my experience in Indonesia, we have 97.3% of success rate. This is something that I never imagined could happen before. I see my patient like it very much. They're happy with that. Even we have a few patients crying, the family crying when we said there are a few of my patients that fail from the conventional regimen. So I said, okay, let's try this new regimen. We have a new regimen for you only for 6 months, and the side effect is tolerable, manageable. I'm very sure we can take it. And now we have more than 2,000 people and regimen participant or patient because it is already as a national program approach, not just operational research. We finished operational research in 2023 with a good result, 97.3 or 0.6% success rate. So we are very confident when we tell our Minister of Health, our Minister even, Pak Budi said, Mr. Budi, this is a very good regimen. We have the data, and you can, I will present to you this data, and he's buying in. And he said to the NTP manager, start this as a programmatic next week.
That's
And all
amazing.
the NTP and the staff are very busy trying to do this as a programmatic approach. And now, as I mentioned, we have more than, I think is, I'm not mistaken, 2,132 in BPAL-M and 160 patient for BPAL, meaning for pre-XDR.
That's
And
amazing, Arlerina. And we actually
yes,
have Joy on the call with us today as well, who was treated with the BPAL regimen in the Philippines, one of the first people to be treated in that country. So now we're actually going to shift over to him to hear a little bit about his journey through drug-resistant tuberculosis and his experience being cured by BPAL. Thank you so much, Dr. Erlina. You are amazing. Keep up the stellar work. Stick around for the panel, please, too.
thank you.
Hi, maayong adlaw kaninyong tanan or good morning to each of every one of you, especially to my TB People Philippines family who are actually watching right now. You know what, guys? I'm not really expecting this to happen in my life. To be a keynote speaker for this event I'm so grateful to TB Alliance, to Robin for this opportunity. By the way, my name is Jojin V. Mangilaya, or you can just call me Joy. I am from Tupi, South Cotabato, Philippines. You know what? I work in tech for several years here in the Philippines. So telco and IT staff have been my jam. But life decided to toss me a curveball. I am a active gym goer, had a healthy lifestyle. I used to be a party animal too, so I hit the town, drink a bit too much, and I smoke and vape a lot. So I don't give the best care of myself during that time. I was living in Cebu when pandemic and Typhoon Odette happened. So the Typhoon Odette is the biggest typhoon that hits the Philippines. So which meant I have without water, food for 4 months. I even drank a dirty water just to survive the thirst. Can you imagine that? No electricity, black off from the world. My immune system took a hit, and all of this lack of essentials, stress, it all came crashing down on me. And my previous partner before got diagnosed with tuberculosis. That's how, because the protocol says that each family member of the patient must undergo screening. So that was the time that I got I got diagnosed with tuberculosis. You know what? I felt totally fine. No cough, no sickness. My chest X-ray was cleared. Even my sputum was negative. But my gene expert says that I am DRTB. It all started back in February 2022 when my health center put me on treatment for drug-susceptible tuberculosis. After almost 3 weeks of this regimen, I end up to the hospital because of the side effects of this treatment were impacting my liver. So my liver enzyme rose up because of this drugs susceptible tuberculosis. So the doctor and I end up to the hospital because of the side effects of this treatment were impacting my liver. So the doctor told me at this point that I had the RTB and they started me again with a 9 months treatment. The standard short oral regimen, so SSOR. Sounds sci-fi, but guys, it's just another set of medications. That one lasted for only 2 weeks before they had to inform me that I was a MDR-TB or multi-drug resistant tuberculosis, and they switched me again into 24 months regimen. Imagine that, taking 20 pills per day for 2 years. That's such a crazy long time for me. They gave me this medication or regimen that felt like a sex job. TB wasn't messing around. I was depressed. After just 1 week of all these pills, I went back to the hospital because of my health was deteriorated due to the side effects of the existing regimen for the RTB or the multi-drug resistant tuberculosis. After this point, I had lost all hopes. I had lost trust in the health workers. I don't want to continue my medication because in my head, the TB, the adverse side effects of this medication making me sick, not the tuberculosis at all. I had to consider suicide back then. When I left the hospital, I decided to stop the medication for a week just to regain my energy. But my doctor from PMDT are obviously continuously following up with to convince me to join or to enroll this DPAL operational research program because he actually convinced me that this treatment is my last options. So finally, I switched to BPAL operational research program, which includes the bedaquiline, protomidine, linezolid. That's a mouthful, right? And here's the cool part. The BPAL treatment comes with a promise, less pill, less side effects, and less duration. Imagine that. This novel regimen was like a breath of fresh air after all the struggles that I had. Thanks to the guidance of TB People Philippines and the expertise of my doctors from PMDT University Hospital, Dr. Alimar Nasai, I decided to take a risk. I gave it another shot, and then you know what? Thanks God, it went perfectly fine. And I'm proudly to say that I am the number 7 patient all around the Philippines who survived multi-drug resistant tuberculosis with this treatment. Fast forward to December 2022, and I'm waving goodbye to TB treatment. I beat the odds, finished those meds, and I'm wearing the title of TB survivor with pride. This is the time for change, for us to join forces and to support the use of BPAL treatment in other countries. As a tuberculosis advocate of TB People Philippines, organization led by Miss Louie Cepeda Ate Louie, who is a survivor of TB meningitis along with other TB survivors who I greatly admire for their dedication in helping those with tuberculosis. I have seen the advocate, how advocate and support can make a difference. So that's why I urge the government and healthcare partners to take the lead in making BPAL and standard care for TB patients. People like me who have survived TB are proof that BPAL works. Let's work together, guys, to make sure BPAL is easy to access, changing now how TB is treated and creating community focus on resilience, support, and innovation. We ask for more investments in TB healthcares and education for all healthcare workers about tuberculosis. This means making sure that screening, diagnosis, and all the best treatments are available, free and without stigma or discrimination. Together, we can how TB is treated in the country or in any country. So leading to healthier future for everyone. And as an advocate, as a full-time advocate of TB People Philippines, I've realized that this is not all about the regimens and laboratories out there. It's all about the people. It's the beautiful people is a TB survivor like us, TB people Philippines. So yes, we can stop. Yes, we can end TB, guys. So tibay ng bayanihang Pinay. Salamat, maraming salamat sa inyo. Thank you so much, Robin.
Thank you so much, Joy. Yes, we can end TB, and let's
Yes, we can
fast
end
track the
TB.
cure as a part of the solution.
Yes, Pastor of the Cure.
And thank you so much, Joy. I also want to thank Joy because he shared his story early about being treated with BPEL in a really great video that TB People Philippines put together. We're actually going to share a link to that story in the chat for everyone to go away and watch. But his story is so powerful. It led to him being invited as a keynote speaker at the Union Conference last year. Unfortunately, he didn't make it there. Visa challenges were plentiful all around the world.
Exactly.
But this year he will be at the Union Conference in Indonesia. So hopefully we get the chance to hear him speak then as well. Thank you so much,
Thank you
Joy,
so
for sharing
much.
your
Thank you so
story.
much, Robin.
All right, so now we're going to turn our attention over to a panel discussion, which is going to be moderated by James Maller and is going to feature Fast Track to Cure partners working around the world. So everyone, please go ahead and turn your cameras on and let's get this panel discussion started. Over to you, James.
Look, thank you so much, Robin, and to the team at TB Alliance for the opportunity to join, but also a big thank you to the amazing country partners who are joining me on the panel. I guess the idea here is very much to build off what we just heard from Joy and Dr. Alina about, I guess, the challenges that are very much prevalent for many people affected by TB in many countries, in many contexts, in many places. And those challenges, I think, as we heard from the experts, both from the medical side, but also from the lived experience side, those challenges range from the process of diagnosis, from the duration of some regimens, the side effects of some of those regimens, the effects that those regimens can have on you, but also more broadly, I think, to add to some of those that Dr. Alina mentioned, it can also be a range of other social barriers, policy barriers that can act as an impediment from different people accessing the TB prevention, diagnosis, treatment, and care services that they need. From the side of Stop TB, we've sort of worked with TB affected community and civil society partners to really build a strong community movement, and very much the supporting framework for this is the Challenge Facility for Civil Society grant mechanism. And one of the great things here, and lots of acknowledgement and appreciation to Robin and the team, has been this opportunity to partner together on this initiative. From the side of Stop TB, one of the key elements that the Challenge Facility for Civil Society is really trying to elevate is that around demand creation. And that's what I think we've seen from the four panelists that we have with us today, who are all working in very challenging, complicated, and diverse contexts, but in some other ways also face some similar challenges and have been able to sort of respond to those contexts and challenges in unique ways, but also in ways that are quite complementary. So I think that it's something where currently under Challenge Facility Round 12, we've been able to see some of this support, and we hope that this broader discussion around demand generation and demand creation continues to build in future Challenge Facility rounds, whether that be around BPAL, whether it be around things like diagnostics, like ensuring that we have rapid molecular diagnostics for all people who need them, whether we make sure that we have the best quality drugs and diagnostics for kids, whether it's the way in which our services, the demand for services that are nuanced and can reach key and vulnerable populations wherever they may live, wherever they may be. So these are things that I think are an ongoing piece of work, but it is wonderful to sort of hear the progress here. And, I will now give the opportunity to these four wonderful partners to share a little bit about their experiences. So I think to start here, I would just acknowledge that we have the four panelists. Maybe we'll introduce a little bit as we go through the responses, but to note that we have partners here from India, from Indonesia, from the Philippines, and from Vietnam, all countries with a significant challenge with DRTB, but also countries where there has been some really, some important steps that have been made despite the overwhelming challenges that are evident in this context. So I might, share a little bit, or just ask a little if you can, go one by one to sort of keep the responses to about, 3 minutes each. And then there will be, opportunities for the panelists to come back for a second round of questions. But maybe as well, as part of your introduction, you can say a little bit about yourself, a little bit about your organization, in addition to answering the question. So we might start with Indonesia. And I was wanted to sort of ask you, and just to sort of acknowledge all the work you've done under Challenge Facility and also through this initiative. And I think that you're obviously based in a country with the second highest DRTB burden in the world. There has been some high-level political support in your country, which has also been fantastic, including political will in relation, or specifically in relation to BPAL. And so it would be great if you can, share with us a little bit about the context in Indonesia, the challenges that you've experienced, but also how your work has really helped support some of the changes on the ground. So yeah, over to you.
Yeah. Thanks, James. Hopefully you can hear me clearly.
Perfect.
Yeah. Good afternoon and good morning, everyone. My name is Yeremia Runtu, and you can call me Yere. I'm the Associate Director from the Yayasan KNCV Indonesia. And yeah, I think I am echoing what Professor Erlina says, that this is a combined effort. But I remember in the past 2 years for adopting and expanding the fast track the cure, I mean the people and regime in Indonesia. So the first moment, I think the political will from the Ministry of Health, especially the minister itself, and it resulted from the operation research that Professor Arlina said that its success rate is 97 plus among the 84 patients. And this result from this operational research to not only to add the evidence, but also a big hope for the many people affected by DRTB in Indonesia to receive a safe and effective regimen after a long time have a painful treatment. And the second moment is we held a webinar. Also, we invited the high-level stakeholders in last year, April, in commemorate the World TB Day. And the public is the mainly audience to raise awareness and create demand on this new regimen. And of course, we inviting the Ministry of Health to speak. And after that, the third moment is he want to speed up the adoption of this BPAL and BPAL regimen. So these combined efforts, research, awareness raising, and advocacy to the potential stakeholders and important policy or decision makers were pivotal in securing high-level backing of BPAL and BPAL-M as part of Indonesian TB elimination strategy. And of course, this is enabling from the donor itself, from the Live TB project, from the supply side, and thanks to Stop TB partnership through the CFCS grant and TB Alliance from the FTTC, that this supply and demand side really help Indonesia to one of the fastest country in Asia to adopt and expanding this new regimen. I think I'm stop at that point, James, and let other panelists continue.
Yeah, thank you so much for sharing. And I think, as you said, like your concluding comment there about Indonesia being one of the first sort of countries in Asia to really take this forward. It is a really wonderful development, and something that KNCV Indonesia can be very proud of for their part in helping to bring about this change. In some ways, I suppose that that links nicely into the next panelist, and I think Blessy, the context in India maybe hasn't moved. It didn't move quite as quickly as it did in Indonesia, but in recent times there has been some progress. There has been a little bit more of acceptance, agreement, and a path forward. So it would be wonderful, I suppose, to hear a little bit about the challenges of the DRTB response in India, some of the work that you've done, which has helped to contribute to now having all of these different partners come together in India with a way forward around BPAL. So over to you, Blessy.
Thank you very much, James. I'm just going to share my screen just so that I remember the things that I need to say. So thank you very much. I feel absolutely honored to be on this panel with my friends here. You're right, James. First, let me introduce myself. I'm Blessy Kumar. I'm with the Global Coalition of TB Advocates based in India, but we work globally. And we do a lot of resistance work in India. But it's not always bad. I mean, stepping out of a NTEP ministry meeting to come for this, one of the things the health secretaries and the DDG said is, we need help from you. I said, what? And they said, can you help us find more Blessinas? It was a bit of a joke, but yes. So all resistance is not bad. We can join hands and make things happen. So India for a long time was very, very against BPAL. We knew what benefit it has for people who had drug-resistant TB. But I don't want to delve too much on why that was happening because it's also a little political, so it wouldn't be right for me to make any comments here. But some of the things we heard is that the side effects are bad. There's not enough evidence. I mean, we really can't get into it. We're not sure about the drugs, but we worked together and advocated to counter every one of them. So some of the things, we started work in 2023. Some of the things we did is writing to the Prime Minister, following it up, World TB Day, major social media campaign, videos. We set up an expert think tank, a cross-disease network roundtable, bringing everybody together, the HIV colleagues, the people who use drug colleagues, the sex worker colleagues, the transgenders, TB survivors, everybody coming together and advocating for this. We started a campaign called BPAL is my right. And then we had several meetings with the National TB Elimination Program, and we raised it at every opportunity, whether it was the National TB Forum meeting or the ICMR CAB. We also went on to develop a shorter all-oral DRTB regimen community brochure and a training manual, because we said, once this is rolled up, we always hoped that India will roll out one day. And we didn't want to waste time. We wanted to have the community well capacitated, well informed about what this whole all-oral shorter DRTB regimen was. And then we trained also people, the community members. We completed 2 trainings. And then when we got a complete no from the ministry, we held back. But we continued with the social media, some of the flyers that you can see, really countering and bringing examples from other countries, especially, people like Ibu Erlina have been great advocates, really pushing for BPAL, the successes from other countries, bringing it to our country and saying, if our brothers and sisters in other countries are getting it, why shouldn't we get it? So challenging, pushing back, advocating, supporting, and along with, this is what we as community have done. But I think there are lots of others who also been involved in advocating for it. But I'm very, very happy to say one of the major things that happened was a change in the head of the National TB Elimination Program. I think we engaged in quite a lot of Twitter and, challenging it. Now we have new, And one of the first things she was to announce that BPAL is going to be rolled out, and the training for doctors is already started. And we said, hey, but we've already done our community trainings 1 year ago. So please, let's get this moving. So basically, I think all of us together, and this couldn't have been possible without learning from our colleagues from Indonesia, from the Philippines, from Vietnam, and of course, with that great support and push by Robin from TB Alliance, support from there, from Stop TB Partnership. So it's not just one organization or a few people who can change it. We really need to work together. If we believe in something, and if we know that it's good for our people on the ground, we need to give it all we have to push it until and unless every DRTB person with DRTB gets that regimen. Because if we say we are in TB, we are fighting TB, we will end TB, this is going to be extremely important. Thank you.
Thank you so much, Blessy, for the remarks. As always, very powerful. Really love the BPAL is my right campaign. I think there's a lot of need for maybe the TB community to pick this up a little bit more. We can learn something from HIV here. BPAL is my right. Rapid molecular diagnostics is my right. This is a discourse and approach where I think that there is an opportunity to help shift this a little bit from the biomedical into sort of a really people-centered approach. So really love that. In addition, taking a note out of your health secretary's book, I guess we need more Alina, we need more Joy, we need more Blessies. So I think, I see there's 118 people on this call. So maybe this is this can help us get to the start of the more Blessy Kumars, 118 on this call, and we keep going from there. So I really appreciate your remarks as well. Now, if I can, I'm going to turn to our colleagues from Philippines to Louis. It would be wonderful, Louis, again, if you can also share a little bit around the challenges of accessing MDR-TB treatment in Philippines, and how some of your work has really contributed to the changes that we've been able to see there. So over to you, Louis, and TB People Philippines.
Thank you, James. For those who doesn't know me, I'm Maria Eloisa Zepedate. My friends call me Louie. I am a multi-drug resistant TB meningitis survivor back in 2007, and I am totally blind because of the lacking access to diagnostics that year, and also there's no BPAL that time. My observing physician, luckily, is Dr. Thelma Tupasi, the one who discovered the resistance treatment for tuberculosis. And luckily, I am one of her patients enrolled to the treatment in the country. Thankfully, I was able to finish the 24 months of treatment and injections every day. I went totally blind, and I was closely monitored by my doctors because I'm already having problems with my left ear. So blind and hearing impaired, Helen Keller in the making. So they were able to really adjust my medication that time, but still 24 months of treatment, all of the side effects of the medication that makes you paranoid, makes you have very dark skin, makes you have an inability to comb your hair. So all of these are gone. Thank you for the regimen that we have right now. And I am now the president and founder of TB People Philippines, which is first in Asia, fourth in the whole world. And next month we'll be in Istanbul to meet all of the TB People chapters, 24 national chapters are all around the world. So we will be able to share all of our good practices there. For my group, I'm very fortunate, Global TB Alliance, for entrusting my group. I am a very new group that time, 2020, and they gave me the project for the leveraging innovative faster treatment. And I told them I can only educate the Filipinos. There are a lot of misconceptions about new medical stuff in the country because of the previous problems we had with Deng Baksha. So I told TB Alliance about this, and they respected my plan. to do IEC materials to align with my Department of Health. And we were able to successfully create all of these very entertaining materials online, on print, and we have hosted a lot of shows online. And this would really make us a place for all of the community to listen to, and in laymanized version. So we were able to really go to the sites that where operational research was instituted. It was on 12 regions, and then we believe there are approximately 103 Filipinos enrolled to this operational research, 98% success. And us being just outside of that operational research, we are trying to educate the general public. And if ever there are also laws to follow up, or they're having a hard time to explain to those who are enrolled to the operational research, they go to us. And I'm very thankful that, of course, the research team of the Lung Center of the Philippines, our partner Tropical Disease Foundation, all of them who are partners of Global TB Alliance, trusted us, that the civil society definitely has a role in research, in policy implementation. Because after the 98%, they told me, Louis, you have to make noise about how to make it programmatic. You have to make noise at the Department of Health Science, the inclusion of BPAL in our list of regimens. And it happened last year, December 1, 2023. And I was very happy because all of our media is able to really yield these kinds of attention from, of course, not just the grassroots, but also the ones up there. The ones who are in the government really listens to the civil society. We are a discerning group. We're not activists rallying outside. No, we are the ones who make sure that there's a middle ground for all of these new innovations in the country. And now I'm going around looking for ways to make sure that the enabling environment is there for the country on all of our 17 regions. I'm flying around every single month, and thank you to my team, thank you to Eugene, my social media officer, making sure that all of our locations, everywhere we go, it's published, so that all of our audience in our Facebook and all of these other online, Twitter, and all of these Instagrams, you're able to really show the audience what we're doing. And I can't believe this morning I spoke to a doctor in Region 8, and then she told me, we want to watch your videos every time in Facebook because you're everywhere. And they really love how we portray the survivors and how we understand, of course, the new regimen in the country. Thank you so much. And we won't be here if not for TB Alliance and for Stop TB Partnership.
Thanks so much, Louis, for the reflections. Really liked hearing this angle, I suppose, looking at the some of the communications that you're doing that are so impressive. I think we heard from partners in Indonesia, and then again from GCTA in India, a little bit about some of these communications, but it's clearly something that you've been able to sort of roll out, and not just at national level, but with a subnational level target, which is wonderful to hear. Also, just to really applaud the efforts of TB People Philippines generally. I guess it's a relatively new organization, but you've already managed to grow with 1,000+ members of TB survivors, which is a really wonderful network that's been mobilized and that can help really take forward all of this work that you're doing. So now just to swing to another country in the region, to Vietnam and to SCDI. It'd be wonderful again to hear a little bit about some of the initiatives from the side of SCDI, and obviously noting some of the challenges of doing sort of advocacy and active sort of actions in the context in which you're working, and how you've been able to navigate that sort of challenge. So over to you.
Yeah, thank you, James. And as you said, it quite a challenging time to do advocacy work in Vietnam. But first, allow me to introduce myself. Good morning and evening, everyone. It's my pleasure to be here today on the same panel with very inspiring partners from Fast Track the Cure. My name is Hoa. I'm from SCDI Vietnam. We are a Vietnamese NGO focusing on working with vulnerable populations. And we have been working with TB-affected communities for the past 14 years, and we will continue to do so. So give a little bit about the context of P-PAN-M rollout. That is a good news that P-PAN-M and P-PAN-M rollout was expanded to 20 out of 63 cities and provinces in Vietnam. And also the national guideline was updated to include these new DRTB regimens since the January of this year. So the P-PAN and the P-PAN-M rollout doesn't happen as quickly as we wish for and expect, partly due to the COVID-19 pandemic. But on the positive side, it is taking careful steps to ensure a smooth national rollout in the future. However, from our point of view, we still think that we can achieve both the effectiveness and speed as long as the communities are engaged more and meaningfully. So even that regarding to the very complicated context, like to do advocacy work in Vietnam, we are still able like to do work with the communities. And we think that with the engagement of the community, that they can contribute and also have to address the challenges that are overloaded in the health system. And it is also the first need in accelerating the P-PAN rollout here, particularly and also in other activities in TB programs in general, which is to unlock and to increase the participation of the community. What we do in SCDI is that we work with the communities, whether they are community-based organizations or a system. We support to build here, we call it community system to end TB, or in short, we call it CSET, to build capacity and also to create a synergy of that kind of system to support the rollout. First set of activities that we do is to raise awareness about the regimen, its availability, and the differences with all regimens, with which in Fast Track the Cure, we produce communications materials such as comics, social media posts from the conversation that we have with people with all regimens, people undergoing or completing PPAL, to share their stories and also live experiences. And the second thing that we are doing, that we work with CSET to support people undergoing P-PAN and P-PAN-M in our intensive care model. This is a community-based care model for people undergoing TB treatment in general. And one of our focus is the people who undergo P-PAN and P-PAN-M. In the model, we continue to collect stories and also evidence, not just about the effectiveness of the regimens, but also about the important roles of the communities in the rollout of P-PAN and P-PAN-M. And the third set of activities that we facilitate the space, the platform for communities to engage with stakeholders, both at the national level, like the National TB Program, and the provincial level, like provincial committees, lung hospital in the province, as part of the community-led monitoring. So those three activity sets have to happen at the same time to supplement each other and have the best result to accelerate the P-PAN rollout. So I think this is my sharing from Vietnam.
Thank you so much. Well, that was wonderful, and I think you know, I can hear some similarities between the other countries, despite the quite distinct context there. But a couple of things that I thought, you know, that were particularly useful here was certainly looking at the multi-stakeholder engagement. And I know other speakers have spoken to this, but the fact that this happened both at the national level and at the provincial level, there's certainly, you know, having that two-tiered sort of approach, I think sounds like it could be really, really effective. Noting not just differences in terms of governance, but in terms of province or in terms of policy, but also in terms of financing, can sometimes have a really, you know, a strong value in having this engagement at different levels. And the final point, and you only mentioned it fleetingly at the end, but I'm really glad someone brought it up, and it's this idea of community-led monitoring, and the fact that this has such an important role to play when we're trying to document barriers and respond to barriers, but also to really scale up community engagement and to build awareness and sensitivity around particular issues. For example, new TB regimens like BPAL. So thank you so much for the reflections from Vietnam. Now, I think I'm going to go back again just for another quick final comment from each of the four panelists, and we might do this in reverse. So, wow, you can maybe go first, and then we'll work our way backwards. But just next week, where a lot of the global health community is going to be back in New York, there is another United Nations high-level meeting on antimicrobial resistance. The antimicrobial resistance, or AMR, multi-drug resistant TB is a key component of this discussion. And Stop TB has worked with lots of partners to develop key asks for a political declaration. And we know that it is quite a strong political declaration in terms of recognizing the importance of addressing TB and MDR TB as part of addressing antimicrobial resistance, or AMR. So it's just, I think it would be interesting to hear from each of the four of you about how you see the connection or any of the opportunities to be discussing accessing new regimens, for example, in MDR-TB, accessing BPAL, scaling up BPAL, making sure it's available and accessible for all, is not just something that is really important for the TB response, MDR response, and for individuals who have MDR-TB, but is also part of this broader agenda on AMR as well. So just if I can ask each of the panelists just to take maybe 1 minute to reflect on this, that would be wonderful. So to you, that's like from Vietnam to start.
Yeah, thank you, James. So I think I will keep it brief and very straightforward. So what we want to see in the coming HLM on AMR is the needed inclusiveness, not just in terms of TB and other AMR health concerns are included, but in terms of the implementers. Here I mean who will deliver the change. The communities have to be counted as change makers in all relevant areas to AMR, including and especially in TB. Coming from that, I hope there will be solid commitment, investment, and also actions by state members after the high-level meeting. So over to other partners in infrastructure queue.
Yes, thank you so much. Maybe Louis, do you want to share from the Philippines?
Yes, can you hear me? Am I clear?
Yes, you're clear.
So there. For me, for the AMR, actually the medication, the BPAL regimen is shorter, and whenever I do my site visits, the patients themselves are able to do the medication even with our lacking laboratories on all of these far-flung regions. I mean, even with the manpower problem, I mean, the regions in the country is very fragmented. That's a problem here. But with the situation that this is a shorter regimen and then it's very easy to understand, all we have to do is provide them all of these ADRs that they have to read, educate themselves about. It's all about making sure that we are there to train all of these service delivery facilities. Because whenever we go to these RHUs, referring health units, some of them are just not trained. But good thing BPAL is there. You know, you understand me? I mean, if it's still a 24 months, everybody's gonna die. But because of the shorter treatment, yeah, we'll just have to really iron out all of these manpower problems. The good thing is the medication's there. But I hope in terms of the laboratories needed for our BPAL treatment, every month laboratories is needed so that we can really track, make sure that all of our patients won't have to end up like me, totally blind. It's all a matter of hands-on. Make sure that all of the patients enrolled will be monitored by these health facilities. And even if there's a lot of lesser adverse drug reactions already, we still have to make sure that the manpower needs to be trained properly.
Thank you, Louis. And now to Blessy.
Thank you, James. So for me, no antimicrobial resistant discussion can be, held or will be complete without a discussion and investment into drug-resistant TB. That's the bottom line. We already have the high-level language. We had it in 2023, a high-level meeting on TB. Probably something will come up in the AMR high-level meeting as well. That's fine. But the challenges are translating that from that high level to the person who actually is affected. I think that's where we need to concentrate on. And really, we have such clever social media, young people who are so savvy. For me, you think about AMR, you have to think about DRTB. Can we make that happen? For both of them to go hand in hand, because one without the other, we're not going to, make any inroads into ending DRTB at the country level. Thank you.
Thank you, Blessy. And now finally to you, just to hear your reflections around the connection here between MDR, TB treatment and the AMR discussion.
Thanks, James. I think as part of the FTC campaign, the Fast Track Cure campaign, our work in Indonesia to leveraging the people and access, that's the key message that we want to urge the in the
There's a little bit of
meeting.
echo. Is it? Yeah, there's a little bit of echo. I'm not sure if you're able to address that.
Okay. Is it better now, James?
It's still echoing, but maybe you go ahead if we can't, because it's just a short remark.
Okay, we want to urge the member states at the upcoming high-level meeting to improve the access of the people and regimen treatment for all, because we improve the AMR treatment access by improving the RTB for all. That's all, James, from our side. Thanks.
Thank you so much. And I think, look, those last comments, I think were really, really important to help frame this discussion. Obviously, we're all focused very heavily on a lot of the work that's being done in TB, but it's also important and helpful to also think about how we can elevate the work we're doing and the priorities that we're trying to achieve by tapping into a broader agenda. And I think, Blessy, you summed it up perfectly, is you can't have a discussion about AMR without a discussion about TB. When we see member states making comments next week, it might be good for everyone to take a moment and see what your country is saying. See if they are they're reiterating their commitments to ending TB and MDR-TB like they did last year at the high-level meeting. If you have those connections with government already or the embassies in New York, may be good to touch base in advance to remind them about the importance of the targets and commitments they agreed to last year for TB and the connection with the AMR discussions that are happening next week as well. I note that there will be side events looking at TB and AMR together next week. I know that many people will not be there, but some of those might be hybrid, and so encouraging people to see how they can engage, or if they're from their own country, to again continue the discussion post the AMR high-level meeting to make the connection between the work you're already doing on MDR-TB, on BPAL, and those AMR targets. So look, I wanted to thank Blessy, thank Louis, thank Hoa for the opportunity to have this discussion with you today. Thanks Robin and the team at Alliance for facilitating and putting this together. I think it was really a really good one. We have a little bit of time for some questions, so very happy to kind of pick those up. I see that the question just on side events, Mona. There is a generic one from the UN in New York where you can capture all of these. Maybe if you can, if you drop me a line, Mona, and I'm happy to share with you those side events as a link, and maybe I can also share them with you, Robin, and you could share with the people on the call so that if others are also interested. Just trying to pick up some of the questions. I see that there's one here in relation to Nigeria. One of the things, Robin, I know that you're exploring is some other countries in which where there might be support, but I'm not sure what countries those will be, but I'm not sure if this is an opportunity to touch on that Nigeria question, and you wanted to take that response? It was in the Q&A.
Sure, I do not see the question, but I will go and look at it right now. And I invite all speakers to turn their cameras on now, and all participants on the webinar to pose questions either through the Q&A function, through the chat, or by raising your hand. And we did stick to time so we could hear from you, because hearing from you is a critical part of today's discussion. So the question from Nigeria, let me go and find it, and then I will answer it.
Let me read it to you. Let me, that's easier. How far have you, I guess, progressed to reach people with tuberculosis in relation to the 6 months regimen in Nigeria?
Okay, so I can answer part of that. And then maybe my colleague Sandeep, who is on the call, can maybe be upgraded as a panelist to give any additional details that I might miss. So some of you might be aware that the Fast Track to Cure initiative is expanding. So we currently have a request for proposals live that's due September 23rd, so soon. And one of the countries within scope is Nigeria. So we want to start working with civil society, affected community partners there to raise awareness about the new regimen and to get communities engaged in the TB treatment response and its rollout in some way, shape, or form. I'm really also happy to say that Nigeria as a country was recently trained, the NTP specifically was trained through the new PeerLink Knowledge Hub. The PeerLink Knowledge Hub was launched March 2024 of this year, and it was set up to share knowledge, lessons learned, and experiences of BPAL, BPLM rollout between countries. So it's hosted in the Philippines. We've got a whole team there that's training other countries on clinical, programmatic, and lab and community engagement aspects for fast and smooth rollout of BPAL, BPLM. I see my colleague Sandeep is here. He'll be able to speak more specifically to the availability of BPAL, BPLM in Nigeria right now. Sandeep, over to you.
Yeah, no, thanks, Robin. And predominant, which is a key part of the BPAL, BPLM regimen, is available in Nigeria. It's been available for a while. There was a critical need that Nigeria had about training physicians and others so that they could utilize the regimen. And the peerling program that Robin mentioned supported that training to enable rollout in Nigeria. I believe there are about 60 to 70 experts in the country came together, and the team from the Philippines went down to Nigeria to have that training. So it was a very unusual process in which a team from one country going to another country to share their experiences and know-how in implementing a new treatment, and that has supported Nigeria to roll out. So hopefully that answers your question.
Yeah, thank you so much, Sandeep. I think that was, is really, really helpful to sort of understand that, and hopefully the people asking that question that sort of is supportive. One of the things that I guess might be a really interesting takeaway activity for people on this call is if you're not from one of these 4 countries that we've just discussed around BPAL, it might be good for you to sort of reach out to other partners in your country, to your national TB program, and understand the status of BPAL in your country. Is it accessible to people? To what degree is it accessible? And if it is not, or if it's at a low stage, what is it that's currently preventing this? Because I suppose a lot of the work that the Alliance team has sort of been supporting, a lot of that demand creation work that Stop TB has looked to be supporting has been very much on this issue. So being able to understand that, and that can be something that maybe we would, from the side of Stop TB, really encourage you all to do that, to then understand the current status, and secondly, to work out what could be a plan of action to really help them to ensure that everyone can have access to BPAL and other, drugs, diagnostics, as well as the case may be in your particular country context. Sandeep, I see your hand is up. Is this to respond further?
Yes.
Yeah, please
and
do.
apologies, I wasn't expecting to be invited as a panelist. I didn't see what I was dismissing. I dismissed the request, so I don't have my camera on, but I could join. However, I just want to point out one thing to the community members here, that with India now deciding to implement BPAL, I can't think of any country really among those that have major burden of disease who haven't decided to implement the new regimen BPAL-M. So if a country hasn't decided, if you come from a country where they haven't decided, they're likely an exception. And in which case, you might want to inquire and ask why that the country hasn't decided to implement the new regimens. So just so that you know that if the community in your country is left out, there's something unusual going on over there.
Thank you
Thank
so
you.
much, Sandeep. I think that's really helpful. I know that there's a report called Step Up for TB, which comes out every year or every second year, and it does take stock of some of the status in countries, and that's also a ready reference if you wanted to also compare across different countries as well. Now, one of the questions I see in the that has come up is looking at the question of peer support or supporting people who are on BPAL. And so this is something that, I'll turn to each of the panelists about what is the sort of support that should be, or is recommended to be provided for people who are undergoing BPAL treatment. And I know, Dr. Elena, you touched a little bit on this in your intervention, and maybe you had some initial comments, and then I'll turn to the other panelists as well.
Okay, James, thank you. I raise my hand because I want to address the question. Yeah, my experience in supporting the patient. First, I think education that deliver in the effective communication is very important. Even though we said that the side effect is very uh, little, and then also it's manageable, but we have to explain that from the beginning in order to make our patient uh, not only buying in but confidence to start the treatment, because side effect is that something that they're afraid of because they hear from others. Yeah, and then also uh, have the good capacity building among your patient supporter. In Indonesia, especially in my hospital, I think in many hospitals in Indonesia, we have this patient supporting that they are from the community. Most of them are the survivor, and then they really help. I mean, they listen to their peer group rather than doctors. And also don't forget the nurse. The nurse is a very good uh, communicator, much better than doctors. We are very bad in communication, yeah. So rely on your nurse, educate the patient supporter, and then also make sure that your system is also working, especially for patient and enablers. Because not having patient enablers uh, on in the timely manner, that's really also some challenge, give you a challenge, and may lead to the not chaos. I don't say chaos, but I mean complain, and then also even a very extreme reaction by saying no, I don't want to continue the treatment, even though you said it's only for 6 months, but I don't have enough money to pay for the transportation, something like that. And also have a good mapping, geographic information system that uh, this patient doesn't need to go to this big hospital. It's so far away, so please just go to the primary health center that also provide the same service. I think that is from my experience. Also, listen to your patient. Don't always say that, oh, very less side effect. You will be okay. No, listen to any complaint. Listen to any side effect, even though it's a very minor one, but for the patient it's really something that matter. Thank you.
No, thank you so much, Alina. Like, in many ways, I think there was the perfect response to really conclude this discussion. I think, I really appreciate the fact that you spoke to the roles that different people can play as part of this peer support and patient support, the role that doctors can play, that nurses can play, that the role that others in the community can play, the importance of broader support, in the enablers for the person on treatment, looking at things that maybe fall a little bit outside the traditional medical response, whether it be things like transport, whether it be things like stigma, whether it be things like the relationship with someone's employer. You know, there are these many areas that can be touched upon, that particularly, an area that, like, I guess I would like to just emphasize again, and you made the point very, very clearly, the peer supporters who are survivors play an incredibly important role. They are professionals, they are experts, and they have a role to play in the MDR-TB response, in the BPAL, in sort of the rollout and support of BPAL. And this is something that I think is a really great takeaway from this discussion. So look, I might wrap it up here and hand it back to you, Robin, noting the time. And thank you again to all the panelists for your wonderful, rich contributions and for the discussion today. Back to you, Robin.
Thanks so much, James, and to all of our fabulous speakers and panelists so far. I know Fast Track the Cure TB Alliance is absolutely honored to be able to work with all of you, and is proud to be supporting community-led engagement in the TB treatment response in a diversity of different ways. I'm just going to share my screen one final time so that you all have an opportunity to sign that petition if you haven't yet. So bear with me as I share my screen, and then I will end with a couple of housekeeping notes before we pass over to hear from our final keynote speaker. Okay, so please, if you have not yet used your phone to scan this QR code to sign our petition calling for universal, rapid, equitable access to the new 6-month treatment for DRTB, please do so now. As I've said previously, we are going to take the results of this petition to the high-level meeting on AMR next week to member states and make them know that this is our very specific ask of them to go home with after that moment. We are close to getting to 15,000 signatures, but we're not quite there, and we really want to get to 15,000. So please do lend your support, share it widely on social, etc. I also wanted to flag that there is a request for proposal live right now for Fast Track the Cure to expand into 4 to 6 new countries. If you haven't seen that, Louis is going to put the link in the chat, and we welcome many applications from eligible countries in scope. Particularly right now, we're lacking in expressions of interest from Brazil and also countries in Eastern Europe. I also want to flag that all of our partners you've heard from today, they mentioned different resources and communication tools and educational tools that they've developed. We have a library of all of these resources on the Fast Track the Cure website. Go explore the website and make use of those resources. There's comics, there's videos, there's brochures, there's training materials, there's tons of resources available for you to make use of in your own country. And if you ever want those assets translated into your local languages, if it's appropriate to do so, please reach out to us at info@fasttrackthecure.org, and we can look to help support make that happen with you. I think that's everything from us right now. We will send out a follow-up email to this webinar with tons of resources and information for you. We will have an ask of you to help us virtually hand over this petition. We've put together a really great video featuring all of our partners around the world. So if we can have your help amplifying that next week during the AMR HLM, we would be greatly appreciative. So now we are going to close with a bang and a strong call to action coming from Mira, who is a fierce advocate for access to new TB treatments in India. She has been a big advocate of the BPAL is my right campaign, and she herself is a survivor of drug-resistant TB. So Mira, I will stop sharing my screen and over to you to close us out today.
Thank you, Robin, for introducing me. And thank you, Fast Track the Cure, for organizing this. And thanks to all who joined with us. I am Meera Yadav, DRTB survivor, TB activist, and now part of Global Coalition of TB Advocates. I had MDR TB in 2012, and after a few months, it was converted into XDR TB. During my TB treatment, I had to take daily injections, which was very painful, and I had to take oral drugs around 16 to 17, which was impacted negative side effects on me. Not only did I suffer with this, but also I lost one of my lungs due to TB. Finally, I overcame this disease in 2018, and I was lucky that I got 2 new TRTB drugs, that is called bedaquiline and delaminate. Finally, I cured from this disease, and I and Brinell D'Souza from Jan Swasthya Abhiyan, we filed petition in the Bombay High Court for issue of compulsory license and for access of new DRTB drug. That time, BPAL regimen was not there, but now we are lucky that shorter, safer, and more effective regimen, BPAL or BPAL-M regimen, is available. Till a few months ago, India has not ruled out, but now it is there, and but now it is to be there, and we need to train our communities on BPAL regimen. We need to train our doctors on healthcare workers for BPAL regimen. I have been attended the trainings in Delhi provided by GCTA, and now I'm advocating for it. Now we are doing advocacy for the BPAL regimen, and there is no enough funds for TB. There is very limited communities engagements. So we need to think about on it. We need to focus on more engagement for TB. We need to more investment on TB. We need to train our healthcare workers, especially on BPAL regimen, to access the all communities. I am requesting to all NTP stakeholders and all civil societies, communities, please to ensure that every life are no lost due to TB, which is TB is totally curable. And yes, as we all know, India is a high burden TB country, and that's how we can eradicate the TB. So we need to push, we need to come together, we need to fight together for this battle to eradicate this TB. Yeah. Thank you. And BPAL is my right.
Thank you so much, Mira. And thank you once again to all of our speakers and to everyone who showed up and participated in today's webinar. This is the first of more to come, so stay tuned for future webinars that you can sign up for. We'll also be at the Union Conference in Indonesia as a country consortium, and we'll be organizing some events that you can participate in there. We are ending with 5 minutes to spare. That's amazing. Yes, we can end TB, and let's fast track the cure as part of the solution. Bye, everyone. Thank you.
Bye-bye.
Bye-bye.
Bye.
Thank you,
Thank you.
everyone. See you soon.
Goodbye, everyone.